I just want to give you an update in terms of the group and changes which are coming to the group, which I alluded to last time when we met back in March. Essentially, because of changes to TCST's funding, that's my team, and we won't be able to host this group going forward. So this will be the last meeting that we host, sadly. The good news is, though, that Wessex Cancer Alliance will take over the host role from the autumn. So we're working hard with them to make sure it's a really smooth transition, and we don't expect the group to kind of change very much in terms of its ethos and in terms of its kind of content, and I'll continue to facilitate the group going forwards. So you probably won't notice that much difference, just that the invites will be coming from Wessex, but what we will need to do because of GDPR is get you to re-sign up to a mailing list. So I think the key kind of message is to look out for an email from the TCST mailbox asking you to sign up to the new mailing list. We won't be able to automatically transfer you across, unfortunately. Okay, so no further ado, I'm going to hand over to our first speaker. The topic today was suggested by a couple of our members, and Sara kindly volunteered to come and speak. So it's Professor Sara Faithful from Trinity College Dublin. I'm going to hand over to Sara now.
Thank you for introducing me. I'm just trying to get the slides going. Sandra, can everyone see my slides now? Sandra, can you see them? Perfect. Right, just to introduce myself, I am in the UK, but I work 1 day a month for Trinity College as a specialist in radiation therapy side effects and the Pelvic Radiation Disease Association. I work very closely with and with patient groups to look at how we improve late effects management. So they asked me if I would come and talk, and it's really nice to actually sort of think about from a primary care perspective. So what I've sort of decided to do today, because pelvic radiation disease is a really big topic and I could speak all day on it, to be honest, but really want to think about the impact of it and think about actually what it is and explore the components of the best practice pathway, because 2 years ago, we launched the best practice pathway, which is a consensus document based on evidence that gives you a sort of like a navigation guide about what you can do, where you need to refer, how to assess, what the key evidence base is, and to really help people manage late effects from pelvic radiation. And so what I thought is that I would talk about a very common symptom, one that you're most probably not so aware of, and one that is really very little evidence, but is very common as well. And then open the floor up as I go through to think on your reflections about what symptoms you see in primary care and your own experiences of the sort of patient pathway, so that we sort of really can tease into some of the different side effects. So I hope that sort of meets your needs. So really setting the scene, and you're most probably aware of this, that 79% of people who have cancer treatment in this country, or a diagnosis of cancer, will survive at least 10 years. So we're very much talking about people living with and beyond a cancer diagnosis. And so with more people living with cancer, we have roughly in this country about we have about 3.5 million people in the UK who have had cancer treatment in their past. So if you're thinking about most older people, many of those people you'll be seeing will have had some sort of cancer diagnosis. And what we know from big population level studies that across sort of Europe and in the UK is that people who've survived cancer treatment and living with cancer have poorer health outcomes. So that can be either with psychological issues or with physical health. And what we know is that, like chemotherapy and radiotherapy, age people sort of roughly about 15 years. So you've got people who've got like a past that you might be seeing for other reasons like diabetes or heart disease. And so what I want to do is sort of raise some of the issues around pelvic radiotherapy that may then impact on future health issues. Now, radiotherapy is really important in cancer treatment. It's a curative therapy, makes up about 40 to 50% of all cancer treatment. It's actually one of the cheapest cancer therapies, and is really curative around pelvic disease. Pelvic cancers include prostate, gynecological malignancies, sort of cancers of the bowel. So if you think about it, it makes up approximately 35% of all cases. And we've sort of estimated, because there aren't like core figures, that most probably 100,000 people a year are treated with pelvic radiotherapy. So you will see people who've had pelvic radiotherapy as part of their cancer treatment, whether for prostate or for a gynecological or bowel malignancy. Now, what we know is that late effects are really important, one for people getting back to work, but two, in terms of their future health and quality of life. So I'm hoping that I can give you some tips and some sort of, discuss some of the issues about how we can help these people. So one of the sort of strange things about radiotherapy is that how radiotherapy works is that it often affects the microenvironment around a tumor, and it causes vascular issues. And so it changes like endothelial, the little vascular tubes around the tumor. So anywhere that someone's had radiotherapy is going to have vascular changes. And so radiation fibrosis is often related to some of these endothelial changes. But it's what I would call a moving target, because what we know today in terms of radiotherapy was not delivered 10 years ago. So when you're seeing patients who may have had treatment quite a long time ago, there's a sort of legacy effect. And so radiation side effects don't occur straight away always. They can emerge months to years later. So what you see now in terms of therapy is not what was delivered 10 years ago. The therapy is much more sophisticated. The field sizes have changed. There's much more screening and scanning. So you can pick out the tumor and you can reduce normal tissue damage. So what it means is there's a sort of legacy effect of patients coming through. The other thing that makes it complicated is that new therapies that are emerging, so for example, some of the new emerging toxicities around immunotherapy can have effects on people's previous radiation. So you can have this sort of emerging radiation effect because you've had a therapy 2 years later that has actually stimulated your radiotherapy late effect. So we don't always know what some of the new therapies, what the late effects will be. And it's something that's changing constantly. Now, when I did my PhD, I did it at the Institute of Cancer Research on late effects, and I was told there won't be any in the future, and that was 20 years ago. And actually, I think we see more late effects now because people have multi-modality therapies. And so that sort of cocktail effect of treatment can actually have an issue in terms of, what's the side effect coming from? It's much harder to actually tease out. So this is pelvic radiation disease. So what is it? What is pelvic radiation disease? Well, it is actually a combination of different symptoms which make up a syndrome. So what that means is that some people are much more susceptible to radiotherapy and are more likely to get multiple side effects. So if you have 2 or more side effects, this would be considered a syndrome. So pelvic radiation differs from, say, like acute side effects of cancer treatment. These are things that start to appear maybe 3 months after you've had treatment, or the symptoms may suddenly develop like 5 to 10 years after therapy. And what we know in terms of the prevalence, it could be roughly about 25% of patients will have some sort of side effect. We don't have good figures around it, but what we do know is the sort of therapies that are occurring. So, for example, when you look at some of the symptoms, some are quite common and some are rare. So the sort of combination of them is quite a big area of concern in a way, because you've got late effects that can be urinary, you can have lymphedema, you can have sexual issues, you can have all sorts of issues around endocrine, you can have also issues around things like fatigue that can linger on long after treatment. And we know the prevalence of anxiety for a lot of these patients managing these symptoms, it can be as much as 23%. So, it's the sort of thing that we sort of focus on the treatment and the therapy, but actually that longer lasting effect can be quite problematic for patients. So pelvic radiation disease, one of the issues with it is that we tend to focus on individual symptoms. And so we don't, it's sort of like multimorbidity in primary care. It is that we tend to go, okay, right, you can have something for nausea and vomiting, you can have something for pain. And we don't look at how the symptoms interact. And there isn't really a clear pathway for managing pelvic radiation disease. And what we know is that for majority of people, they most probably have one or two symptoms, they can manage them, they're managed well, but there's a group of patients who have significant symptoms that it's really difficult then to get help. And this was from Joe's Cervical Cancer Trust. They did a report on pelvic radiation, but problems in patients who'd had cervical cancer. And what they said was that if you go to your GP, they don't have an idea about how to manage ongoing symptoms. And you're referred back to your oncologist, who then refers you back to your primary care to say, like, see the continence services or to go and see a bowel specialist. And one patient said to me, I feel like I'm collecting doctors because I've seen all these different people, but actually it's all due to having the radiotherapy for my treatment. And a recent paper by Valeur, which is a qualitative study, found that patients with pelvic radiation disease reported higher psychological distress and overall poorer quality of life than other cancer patients. And also the symptom burden. So, for example, how many symptoms the person had was really critical to actually how high that psychological burden was. And they obviously were more likely to have disability problems, be on disability pensions and not to return to work. And if you look at studies that look at population level, it is the patients with gynecological malignancies who have the most difficulty to get back to work. So there's a lot we could do still to actually improve some of the symptom management. Now, this quality of life research, I don't know if it's a bit blurry for you, but it's a little bit blurry for me, but I'll point out some of the key elements. But this was a population study. What that means, it takes the whole population of Norway, and they actually record how many patients have sort of pelvic radiation disease. And what they found, this is, if it's high here, that means you have good quality of life. And you can see the grey line is what the normal population have. And the blue is that all the physical effects like social functioning, ability, emotional functioning, role functioning are all down. And also things like overall quality of life, almost 20-point difference between that and a normal population. And then on the flipping it, then this is symptoms. If you have high here, it means you have high symptoms. So it's the opposite way around, is that they have more pain, almost 50% more, and then breathlessness, but also looking at things like the constipation, diarrhea, and also things like financial difficulties. So we know that patients who have pelvic radiation disease have poorer outcomes overall. So just sort of throwing this to the group, thinking about your own experiences, and I don't know if you've heard the term pelvic radiation disease, but what sort of are the long-term pelvic symptoms that you see with patients? If you want to put it in the chat and we'll talk about it. And I'll pause here momentarily. And I noticed Jackie's put multimodality treatment has underlying conditions. Totally agree. Yeah. So bowel symptoms and diarrhea, what other sort of things that you've been seeing? Everyone's gone shy, Sandra. Yeah, sexual dysfunction, urinary and fecal incontinence, fear of sexual interaction. Yeah, really common symptoms. And, you know, we can talk a little bit about some of the sexual dysfunction. I haven't picked that out as a key symptom because there is a lot of information on how to manage that, but we can talk a bit about that near the end. But urinary and fecal incontinence is one of the ones that is a big fear for cancer patients, and also then, you know, obviously affecting, like Tina's put about nutritional absorption issues. Yes, you know, these are really difficult things to go back to work to. So, you know, if you're, say, a driver or you work in a shop, you can't be popping off your counter to go to the loo all the time. And things like access to toilets and that sort of thing really impacts then on patients' ability to actually go back to work. So they're key symptoms that can appear quite late after cancer treatment. So the best practice pathway has a really good sort of sections on these different areas. And actually at the very moment, the reason Leslie couldn't do this talk is that she's at the gut meeting up in somewhere up north, but I think Manchester, and they're actually going to be launching new guidelines on gut health after cancer treatment, because the understanding around why some people get side effects is changing quite quickly, and they're updated the gut guidelines, and I'll talk a little about that. But what the best practice pathway is really is to try and give greater visibility to pelvic radiation disease. And when we've talked to patients, one of the things patients say is that they had no idea that you could get late effects, although it was covered in the sort of in the consent form, then they're so stressed at that point of diagnosis that the late effects for radiotherapy are on the back of the form, all the acute ones are on the front, and everyone talks about them as being rare, so you don't even think about them, but then you don't really revisit that near the end of treatment or in your treatment review. And so it's something that then they don't know whether it's something that's normal or abnormal, or should I report it, and should I actually go back to the oncologist. Now, one of the things with late effects is that a lot of the side effects of pelvic radiation disease can be very similar to recurrence. So you have to almost rule out recurrence first and then go, okay, right, this is a late effect. You can't assume always that there is a late effect. So one of the key concepts of the best practice pathway is that it's almost like a triangle in the upside down, like a pyramid, in that you want most people to have some guided self-management, raise awareness that there's information resources, but also the ability to navigate organizations. So what we found as a group when we were doing the consensus document, that each regional alliance has different approaches to what they provide. Some services have late effects coordinators who manage late effects, but they're relatively rare, or that it's very much passed back to primary care. And so when you're actually sort of, if you're having a management of a lot of patients, you really need to know what your alliance provides in terms of, is there a specialist late effects service? Who can you refer to for gut problems? Is there extra information that you can provide people? Then the Pelvic Radiation Disease Association have a helpline, and also they have information resources. So if you have someone who has multiple symptoms, pelvic symptoms, you can refer them to the Pelvic Radiation Disease Association. And as a group of clinicians, we all then have referral pathways that we can advise people on who is the expert in this field for people who have really unusual side effects. And the idea is that we then want to optimize referral pathways. So obviously, if people can self-manage and at local level, but also to have better assessment, but also to know what you can do yourself and when you should refer. And part of the book, the best practice pathway, was to try and help people set up service models and do business cases and find supporters. So there's a group of collaborators that you can contact who can help you to actually do a business case for and think about commissioning if you've got a lot of patients who have late effects. So the idea is it was primarily aimed at clinicians. But we've had a lot of patients using it as well, saying this is what I'm meant to be having, you know how it happens. But also we've had a lot of contact from people in Australia, in other countries, who've said, you know, it's been really helpful because I can then go back to the services and say, is there anything available? Can I have this assessment, or can I have this? So I'm going to pick out one symptom, which is I'm actually based, my main work is around urology and pelvic care. So I'm going to take this one first because it's really common, but is often quite not poorly managed, but is something that we think we know how to manage, but often we don't always manage that well. So with pelvic radiotherapy, one of the common symptoms is bladder problems, and radiation cystitis is very common, specifically in gynecological cancer, where people have had brachytherapy. So if you think about where the bladder lies, but also in terms of all the different tissues that you go through to actually affect the bladder. And things like urinary incontinence and leakage are huge stigma issues around sexuality, but also in terms of people's social and role functioning. And less common, we see fistulas and strictures, but strictures are more common in prostate cancer, where you've got the sort of prostate round the tubes. And what happens is that over time, people have retention, which may not be picked up. And then you have to stretch the stricture early. So they have to be picked up early. Otherwise, they have to have a catheter. So it's one of those things that if you can pick it up early, you can manage early, you actually prevent a lot of clinical issues. And it actually does have a very strong link to poorer psychological health. So just this is a radiation, just an MRI showing radiation fields. And if you can, this is obviously the pelvis and the sacrum. And you can see here, this is the sphincter here. This is for prostate. And you can, this is a sagittal view, but you can see the bladder neck here. So normally we say to patients when they're having radiotherapy, fill your bladder, it pushes it out of the radiation field. But the base of the bladder is really critical to actually irritation of the bladder. And this is where the nervous system for the bladder is situated for wanting to go. So after radiotherapy, a lot of people have this frequency, and it's because of the high dose of radiation that you get to the bladder neck. And, you know, we used to do bladder retraining to try and get people you know, sort of thinking about, you know, how to manage some of the symptoms. It isn't just that the bladder is totally irritated, it's a hot spots on the bladder. So, you know, when you're looking at this, you can see the tubes here go through the middle of the high dose field. This is where you get strictures in the urethra, but also you can see here the rectum at the back is very close to the radiation field. So this is why you get gut problems in the rectum in terms of damage. So it is a sort of key issue. Now, I've had a question come up in the chat, so I'm going to just stop momentarily. And it's from Asana saying that, you know, this is helpful. The evidence base is really good to see. And there's a huge gap in service planning or QI work to know how many people there are. Totally agree. And this is something that would be lovely to address in the future, because we know how many people are having radiotherapy. We collect that data, but we don't link the quality of life data that we collect to treatment data. And it's something that I've sort of, I know it's on the wish list of things we would like to, to do in the future. We have it in other countries like the Netherlands and Norway, but we don't in this country. But also it is about, I know Amanda's put, just thinking, how would you know if a large population of people had late effects? Well, for example, one of the ways that we map late effects in studies is we look at what drugs are being given out to cancer patients. So your community pharmacist is really helpful here, because you can look at, say, for example, how many patients with prostate cancer who've had treatment are being given Flomax, having bladder ultrasounds, and look at some of the issues. Do they have other issues? Are they having rectal problems? What sort of painkillers are they on? And it gives you more of an idea of potentially of how many late effects you might be having. In Wessex, they do map the late effects through PROMs, so they know how many patients have got side effects, and then they refer them in to the late effects service, where they do a detailed assessment and pull their treatment records. So that's a really good question, and I think it's a gap in what we do, because we know about chemotherapy drugs, we keep good records on that, but in the study I did not that long ago in prostate cancer, only 45% of patients had any detail about their radiotherapy in the GP record. It just had radiotherapy, and it didn't say what dose, whereabouts. It didn't have any diagrams of the field size, so you don't know necessarily whether it is a radiation effect. But I'm sort of flagging it up because I think it's important to understand the differences between the symptoms. So the other thing, I'm harping on here, I'm on my pet topic, but pelvic radiotherapy goes not just to these major organs. What you forget about is that the whole of your pelvic floor is muscle. And as women who've had babies, you most probably know that. I do ballet, and a couple of girls have just come back and they daren't do the jumping sequences because their pelvic floor is weak. But when you have radiotherapy, we know it affects the pelvic floor muscle strength. And if you look at all the different muscles around, like the rectum, everything like that, to actually improve continence control, you've got to improve your muscle structure and your muscle pelvic floor. So there is, a lot of issues around this, in terms of, you can't just think about, oh, this is a bladder, we'll give someone Flomax. You've got to think about their pelvic floor too, and whether it's a stricture or whether it's irritation from that sort of neck of the bladder where they've had radiotherapy. I'm seeing some good chat coming, and I might take that in the next gap, if that's all right. So one of the things that the best practice pathway does is it gives you at a glance, which is quite nice because it's quite a big meaty document. And what we always suggest is that you actually do a bladder assessment with a specific symptom question. So like the IPSS is only 8 questions. It's really easy. The ICIQ actually covers incontinence, and there's a female version and a male version, and that's a short questions, very easy to do. And you ask patients what's the impact, and if it's over a certain level, you would actually then maybe call the patient in, do a physical assessment and see whether they have bladder retention, whether it's an issue in terms of a stricture or whether it's just irritation. You've got to, for bladder cancers, rule out recurrence, but also you've got the person's holistic needs assessment. Urinary problems are in there as well. And in the document, there is like detailed tables with the references and the sort of the best practice management. But one of the things with lower urinary tract symptoms is if somebody's got lots of frequency, but can, I would normally get them to do a bladder diary and measure, and give them a jug, get them to measure their urine and do a diary. If they can do like, 100, 100 mils, 50 mils, 100 mils, 50 mils, and then go to the cinema and manage to hold 300 and something in their bladder for 2.5 hours, or they're watching telly in the evening and can hold a large amount of fluid. It isn't the bladder's shrunk, which is an often misconception that patients have. They're often told their bladder has shrunk, and that very rarely happens because the bladder is not in the radiation field. It's the base of the bladder. And what it is irritation, and they then keep on going to the loo. If you retrain the bladder by bladder retraining techniques, let them say, wait 10 minutes, don't go, and you can extend that time period, and also teach them pelvic floor exercises. Now, if it's that they do very small amounts all the time, then you've got to think it's a stricture in relation to, say, for example, prostate cancer, where the urethra is definitely in the radiotherapy field, because it usually means that they've got bladder retention, and a bladder ultrasound or a palpation usually will tell you if they've actually still got fluid in their bladder. So these are all what I'd call bread and butter things that you most probably do in primary care around continence management, and you most probably have people in your practice who specialise in this. What is often problematic, I'm going to just see if I've got a management in here, but so here we are, storage symptoms. This is where you basically patients are going all the time, frequency. There's a bladder app you can use, but teach them pelvic floor exercises. If they're doing, they've got post-micturition symptoms, so for example, leakage after they've been, because it's usually the pelvic floor, you can then do these sort of double voiding techniques where you get people to sit and then stand and then sit down again, and that helps. One of the problems with pharmacological management is that they have a lot of side effects, and if it doesn't work within 6 weeks, it's not going to work. And you can buy Flomax over the counter. Tamsulosin is an alpha blocker. It really affects blood pressure in older people, and can have a lot of issues in terms of dizziness and stuff like that. And so if it's not working, then you've got to think of more in terms of what's the physiological cause for the person's symptoms. The other thing to think about is radiation cystitis. And this is really common in gynecological malignancies, more so than maybe in prostate. But what you see is this change in the endothelial. Now, we think of the bladder as being like a balloon, but it's actually an organ that has lots of layers in its tissues. And what happens is you get this sort of like like telangiectasia, where you get like a spider nevi on the skin. You get the same vascularization on the bladder wall. And you get the same in the rectum as well, from where the radiotherapy is, and they get bleeding from it. Now, for some patients, the bleeding can be so bad that they become anemic and are fatigued. So if someone's fatigued after gynecological cancer, do a dip test and see if they've got hematuria, because their bleeding can be so significant. You may not see it, but over a time period, it can actually reduce their iron reserve. And this radiation cystitis needs specialist management. If it's very small and it's sort of 1 or 2 times, it's not such an issue. And what you'd say to people is, don't have concentrated urine, drink more fluid, that sort of thing. But if it's very significant, they've got cystitis, it hurts, it's painful, and it develops after treatment, they need to have a cystoscopy and have referral to a specialist centre. It's about 14 to 16% in women who've had a gynecological malignancy, and especially if the radiation bladder dose is more than 60 gray. But there's lots of new therapies coming out, and it needs specialist management, because if you laser those telangiectasia, you burn a hole in the bladder. So it's got to be that they've got to go back to a urological centre that is used to dealing with radiation side effects. So you really need a proper tertiary referral if somebody's got hematuria that you're seeing in primary care. They often need dietary support for anemia. We always say avoid constipation and increase fluids. And think about whether they're on any anticoagulants, like aspirin or any of the other anticoagulants, because that obviously can make it worse. So it's something that really we don't necessarily address that well. When people have cystitis, the recommendation internationally is for them to have hyperbaric oxygen, but a lot of these hyperbaric oxygen centres have closed down. And the MS ones that are for patients with multiple sclerosis aren't at a high enough level of hyperbaric to really make a significant difference to patients' late effects. So yeah, someone's posted the Squeezy app, really good for teaching pelvic floor exercises. So with my patients who have prostate cancer, I would always teach them pelvic floor exercises, whether they have surgery or radiotherapy, and also for women with gynecological malignancy. Anyone who has radiotherapy, external beam that goes through the pelvic floor, and brachytherapy, the pelvic floor muscles will be impacted. And there's been some studies in Denmark that show if you do pelvic floor exercises and train people how to do it and keep sort of like reiterating, you need to do them, then they have something like a third less side effects in terms of urinary and bowel. So, these are things that are quite important in terms of managing continence, but also improving people's ability to manage their own symptoms. And in Denmark, they start the pelvic floor exercises before they start radiotherapy, because most older patients have poor pelvic floor before they start treatment. And one of the things, thinking about the service model for radiation, in urinary symptoms, there's a really good service model, but it may not necessarily be set up for looking at radiation cystitis. And so you may need to have somebody who has an interest in the area. Like in London, there's a particular centre, like Guys and Tommies do radiation cystitis. And, the specialist secondary care in terms of pelvic physiotherapy, all those sort of things, you most probably have access to help patients with your own urinary continence services. But there is no standardized model, and that's something that we talked about that would be really helpful. So I'm going to talk, I think before I go on and talk about, I'm just looking at time. I'm going to talk a little bit about fragility fractures, because women with gynecological malignancies can often have pain after radiotherapy. And I don't know if this is something you see, but what we're beginning to understand with better MRI technology is that patients get changes to their bones after they've had cancer treatment, partly because they have an early menopause. So obviously they have a drop in their vitamin, their whole ability to manage bone health. But also that the radiotherapy causes vascular changes in the bone that mean that they can get microfractures in the neck of femur. And what we know is that it develops suddenly. So often patients will do something, they often say they've been out digging in the garden, or they sat heavily on a wooden chair, and then from then on they've had this pain. So these are sort of like warning signs. And it develops in the pelvis, and it can occur between 8 and 20 months after pelvic radiotherapy. And obviously it has the risk factors. We really don't know what they are. There's work going on in Manchester to look at it, but what we know is that smoking is a risk factor because of vascular change, but premature menopause, but also low BMI. Paradoxically, if you're osteopenic or if you've already got osteoporosis, it doesn't mean that you're more likely to get fragility fractures from radiotherapy. We think that the action is slightly different. But what it means is that you need to think about, if a patient who's got pelvic radiotherapy and has got other symptoms, and then they're talking about pain as well, they may have multiple effects because of that sensitivity to the radiation. So if you look at, this is from the study that's been going on in Manchester, and I took from the paper. But what they found is that the lumbar vertebrae are also included in that. So 7% of patients, majority it was sacral, and usually from sitting on something that was hard, so that was sudden like break, and also in the femoral head. But it's mainly pubis and sacrum where you see these microfractures. And the thing is it's really, what do you do for management? It's not like you're going to have a hip replacement for a microfracture or something. But for a lot of the women, it's a really big problem in terms of mobility. And the sort of guidance, this is showing you where the fields come in, and this is where the red is where the main dose comes in on radiotherapy. But you can see this is the head of femur. The radiation goes to all the sacral area and the acetabulum, and you know the bones are very sensitive to radiotherapy. So this is a qualitative study looking at the impact, and this was from Sally Taylor from Manchester, and what she said from patients was that the information around it is quite poor. It really affects their quality of life, but also they feel quite angry about that they've got all these problems post-treatment, and that they didn't have any mention of fractures during the cancer treatment, and that they've often had so much to read, they hadn't actually picked that out. But also that when they've had pain, people have dismissed it rather than actually go, well, let's investigate, let's talk about this. How long since you had radiotherapy? It's not just a backache, it might be more significant. So in the best practice guidance, a lot of the management is not evidence-based, it's consensus-based for fragility fractures. So what they say is that you need to have imaging to exclude bone metastasis for a start. So again, going back and referring back to oncology, looking at vitamin D and bone health generally. Bloods on that to look at vitamin D and calcium. Refer for a DEXA scan to see if they do have any metabolic bone health issues, but also the whole thing around explaining that it could be caused by the radiotherapy. It usually is transient. So if they rest up, have pain control, and also some rehabilitation around it in terms of not doing too much around that area, offloading some of the sort of the joint pain around that, then they often improve. So it's one of those things that there's talk about, should people who have these these bone health issues have statins, because it could help reduce the fibrosis and improve vascular control. So there's a lot of work going on around this. So I think it's a watch this space. And this is one of the emerging toxicities, because we're giving higher dose radiotherapy in smaller fields, but they go through the bone. And so we're beginning to see more of this. And you may see more people who have this sort of pelvic pain. A lot of patients said that they have reported it, but it's always dismissed. So that's, I think, partly why we don't know, because it's not one of the core, like nausea, vomiting, bowel problems, urinary problems that are in the quality of life information. So this is something that is new. I'm going to do one more, and then we'll go back to the questions because I'm conscious of time. But I wanted to talk about skin, because I don't know if you've noticed that when someone has like a breast radiotherapy put in the past and they had a square field, you'd have a change in skin colour, especially in darker skins. What we see in terms of pelvic radiotherapy is you get the same in the pelvis, and especially in different skin tones. And I think it's really important to recognise that, because for some people it's a really big problem. And we estimate that about 20 to 30% of people after radiotherapy have skin changes, either with a fibrosis where it becomes less flexible, and the hair loss in the groin is so you lose your bush basically, and it may not grow back. And that skin discoloration can be very unsightly. Now, although for many people they go, well, nobody can see it. For some people, it's a really big issue psychologically. And that chronic inflammation and radiation fibrosis continues after cancer treatment for a long period of time. So you can get this radiation recall dermatitis, which is where somebody then has a follow-up drug in terms of adjuvant therapy, like an immunotherapy, and it basically induces an acute skin reaction where they had their radiotherapy, and you can see the field outlined. And this is something to be very aware of where patients are having further therapy for maybe a recurrence. And it causes a high level of distress. So if you can see the skin here, this is like the initial exposure, you've got the radiation and it causes inflammation, and you get this acute skin reaction, which then is transient and goes after you finish radiotherapy. But the radiotherapy has initiated an inflammatory response, and it's a bit like sort of letting the Incredible Hulk out the bag. You've got this inflammatory response in your skin, and what happens is you get fibrosis and you get this inflammation, and it sets down collagen. Now, it may not be a problem if it's on a flat surface, but if you've got this in your groin, if you've had vulval treatments or anything like that, it can restrict your movement in your hip joints, and it can also restrict movement in your vulva. So like sex can become very painful, and it can be very distressing for patients. What we know is that the hyperpigmentation is a real problem for patients. And what we often say is make sure if you're sunbathing or going out that you wear high factor all the time in that area if it's exposed in the summer. But also things like massage can really help. There is some evidence that pentoxifylline and vitamin E can help with the fibrosis, but also things like photomodulation, where you sort of rub that the skin is lasered, and it creates a sort of response. But also things like pravastatin as a secondary prevention. So someone who's already beginning to get fibrosis, give them a statin, it reduces the fibrosis. The second line treatment is fat grafting. Now, you try and find someone who can do that in the NHS, it's really difficult. And there's only one centre in the UK that does it, which is the Royal Free. So this is something that, although it's not going to kill you, it's really distressing for patients, and patients complain a lot about loss of hair, changes in skin color, and feel like it's very unsightly. And if then they have things like ulceration or poor wound healing, it's really difficult in the groin to try and solve that, because it is a surgical referral and needs skin grafting, really difficult to do when you've had radiotherapy. So the fragility fractures, relatively rare, because we think they're rare, but we don't know. We know that the skin problems are high level, 20%, perhaps more, but because it's not life-threatening and it's sort of often hidden in the pelvis, it's not like on the head and neck, there's very little research and very few services on how to manage from a dermatological perspective these issues. And this is where you might have a friendly dermatologist or a GP who has particular interest in your practice, who might have an interest in this area. So there's work going on, but it's fairly scarce, and it's something that we really need to improve. Pentoxifylline, we really don't know. They talk about vitamin D, E, but the studies are really poor. And there are MOS guidelines for radiation skin reactions, and this is a really good overview of acute radiation reactions, and they have a little bit on late reactions, but really there's very little guidance out there. So I'm going to talk about the service models. We talked a bit about that. There's only one study, which is at the Royal Free, on radiation skin fibrosis. And most guidance is based on head and neck because it's visible and causes a lot of issues around the neck movement. And But pelvis, it can result in lymphedema, it can result in pelvic tightness, skin, lots of problems around that. So what I would say in terms of the best practice guidance is that if you're particularly seeing a lot of patients, like with sort of gut problems, those sort of things, watch out for the new gut guidance. And I can send Sandra the new guidance when it comes out to send to you, because one of the things with like the gut is you've got to think about the microbiota, which we know, the microbiology. So we know that when you have radiation, it affects the bugs in your gut, and that some of the diarrhea that patients get is often either to do with bacterial overgrowth, or it can be due to bile acid malabsorption, and trying to work out which is difficult. But the guidance has a sort of is focusing more on what could be a primary care solutions for it, and then when do you refer. So I don't want to say too much about it because it may have all changed. I'm not at the meeting. But the guidance will be published, and I'll send Sandra that, and that can be circulated to the group. But it is actually much more complicated than just giving someone loperamide. It is thinking about what sort of diarrhea they've got, have they got microbial, changes in their microbiota. And, the future might be that you have to have a gut sort of, a little drink of gut bacteria or an enema of somebody's microbes, and that will solve your diarrhea. I don't know. But a lot of the assessment at the moment is very much about, is it bile acid malabsorption? Screen that out. Is it due to that they're actually have got changes to the microbes, and bad microbes have grown and they need antibiotics? So in the guidance there's a link to the Macmillan gut guidance, and that's the sort of current guidelines, but I think they will be changing. So watch this space and I'll keep you informed. So thinking about what you can do as healthcare professionals, I think the first thing is you've got to always rule out when someone comes with side effects that it's not recurrence or progression or cancer. So if they've had a recent scan, been checked, they haven't got recurrence, and they're coming to you for side effect management, then you're sort of fairly confident. If you're seeing a patient for something else and they've had radiotherapy and they're coming to you for something that you think is not related, you may have to refer them back, especially around gynecological malignancies. But have that conversation with your patient, especially in the end of treatment reviews, about what sort of late effects may they get, potentially they might get. You have to say potentially, but if they've already symptomatic on some things, they're not necessarily just going to disappear. They may get worse over time. And if you look at people who have bowel problems acutely during treatment and post-treatment, then their symptoms will continue unless they're addressed. So use this best practice pathway to think about managing symptoms. So it's a sort of, you can flick to the section, but also there's lots of services, signposting and resources like the Squeezy app and things like that you can refer patients to that can help. And also it sort of tells you what services you can find. And the Pelvic Radiation Disease Association keep a sort of like a map of where you can get what, and if there's a specialist who's interested in this area who will take tertiary referrals and stuff like that. And think about referrals to other services that you might have, like your continence service. Maybe send them a best practice pathway, but also think about, if you've got other clinics around like bone health, is this something that you could refer patients to improve their pelvic floor in terms of their bone health and fragility fractures, or do you have other clinics that can actually help patients? So there's a lot of change going on, but the first thing is you've got to find out whether people have these problems. A lot of patients feel it's the price to pay, and actually it shouldn't be. We should be managing these in a much better way. So
There's a few questions or comments in the chat, so
I know,
just
and I
pick
think
up.
a lot of these relate to, I think, is you know, how can we, what we do things. So let's go back to the chat, because this was really just a timeout activity to find out what, in case you hadn't done any chats. So let's go back to the chat. So I'm going back to the one where Tina had said about the any NCICB to look at both these issues, work ongoing about cohorts 5 to 10 years out of treatment and the quite disastrous effects of those who are going through treatment now and need to be armed with information to support ongoing care, and mapping and building services across all stakeholders. Yeah, I think there's a greater awareness now that people don't come out of cancer treatment unscathed, and especially with adjuvant therapies going on for many years, you know, we need to be more aware of how the knock-on effects of them. So it's great that there's work ongoing. And I think coding is really problematic in primary care for some cancers. Like there's 8 codes for prostate cancer, depending on what treatment, but there isn't any coding for late effects. I'm involved in a study on the steering group, and we're trying to map the coding. Now, the best practice pathway has the codes for primary care in the back for the different side effects, so that you can code them appropriately within it, so we can map. But I agree, we need a standard data set. It would be really good to do more work on this. Maybe in the future, you know, we need to do that deep data dive. And if we could link the quality of life studies with the treatment data, we could know then if people who are having higher dose have poorer quality of life, or, you know, whether there's other issues. So, for example, in the Netherlands data set, one of the key things was social inequalities. Those people who come from poorer, more social inequalities have a higher level of side effects, often are smokers, but overweight. You know, there's all sorts of other factors, or they don't have access to things like physiotherapy or private services, yeah, that they can then go to, like psychosexual counselling, or they can't get to those services. So yeah, we need to look at who are the people at highest risk and focus more of a preventative management in earlier in the radiotherapy journey, like the pelvic floor exercises. Yeah, no, I agree. A standard data set sounds really good.
So I'm just
Squeezy app
aware of
has
the
been
time,
shared.
Sarah.
Pardon?
Sorry, so I'm just aware of the time. It's 2 o'clock. So
Yeah, it's time. I'm just going to flick
sorry,
down. There's a lot of
so
sharing of
much to
outcomes. Yeah, I think I've answered all the questions. And someone's asked if I can share the slides. I'm happy to share the slides. All the data has been published, and the best practice pathway has all the referencing in it. So I would say go with that as well. Pull it off. It's free. Access it. Have a look at it. So yeah. And always get in touch with you around particular areas if you need to.
Thank you. And thank you so much. There's such a comprehensive overview of the subject. Yeah, shame when we have to squeeze it into an hour, because I
it's
think there would
such a
have
big
been quite a lot
area.
of
So
stuff to
thank you
discuss as well.
thank you for
Yeah,
letting me talk.
I can see there's a couple of hands up. I think we need to draw it to a close. If you want to put your questions into the chat, what we can do then is, if anything we need to fill back to Sarah, we can do so.
Yeah.
And the slides I'll share. And there's a colleague, Tina, has talked about what she's doing in North East NENA, which I can't remember what NEA stands for, but she's happy to share her work. So Tina, I'll get in touch and I can share that with the group as well. So it just leaves me to say thank you for your presentation and your time in talking to us today. It's very, very much appreciated.
Thank you.
Thank
You
you
very much.